So in our annual Congress, we divided the various uses of liquid biopsy into several tracks or sessions. The session I chaired was on current clinical application. We also had sessions, of course, on more basic research, on translational research, and on future directions. But in my track, we had several speakers talking about what is the current standard of care for liquid biopsy in different tumor types, in different situations. My own presentation was in non-small cell lung cancer. And what I described is the current role and the emerging roles for liquid biopsy across what we call the continuum of cancer patient care. And what that means is going all the way from liquid biopsy helping to screen patients who are at risk for lung cancer, all the way across early diagnosis, post-surgical use of liquid biopsy. This is a space called minimal residual disease. And then patients with advanced disease, how liquid biopsy is being used for molecular testing to determine what's the best therapy for that patient. Should it be a targeted agent? Should it be chemotherapy? Should it be chemotherapy plus immunotherapy? And then finally, and this is the most common place where liquid biopsy is used for non-small cell lung cancer right now, is in a patient with an oncogene-driven cancer, EGFR mutated, ALK translocated, who has been treated with a tyrosine kinase inhibitor for that cancer, and they've responded. And now maybe a year later, they have resistance, they have progressive disease. Using liquid biopsy to determine what is the mechanism of that resistance, and then tailoring the next treatment based on those results. And there are two broad categories here. One is that the resistance could be within the same pathway as that original mutation. So an example here would be a patient who has an EGFR mutated cancer. They get a drug, first or second generation TKI, and then they develop resistance. We can use liquid biopsy to determine the most common resistance mutation, T790M. If they have it, then there is an additional drug, a third generation drug called osimertinib, which is the treatment of choice. Of course, some patients may get osimertinib first line, but that's a good example. On the other hand, they may have what's called a bypass mechanism. And these would be things like MET amplification, or even new mutations, such as a BRAF mutation or a RET fusion, for example. There are now a number of studies which I reviewed, which show that the use of subsequent therapy is better, and the results are better, if you look for the mechanism and if you treat based on that mechanism. A very good example of this is the ALK TKI lorlatinib, where recent studies have shown that if it's a secondary mutation resistance in that same pathway, then the response rate is about 70%. But if it's a bypass mechanism and you use that same drug, the response rate's only about 30%, and the progression-free survival and so forth match that. So more and more, we're now in the business of precision medicine, individualizing treatment for each patient. And liquid biopsy is really leading the way. And non-small cell lung cancer, because of the large number of targets and oncogenes, it's a poster child for liquid biopsy.